Hi everyone. Hi, my name's Claire Aldridge. I'm going to be chairing the session today. We're just going to give people another minute to join. We've got lots of people coming in, which is fantastic. Fab. So lovely. Let's get started on today's session because we've got lots of fantastic stuff to get through. So first of all, a very warm welcome to everybody to our first webinar in our webinar Health, Equity and Action series. Today's webinar we've titled then Equal Path to Care, Rethinking Access to Physiotherapy. My name's Claire Aldridge and I'm a professional advisor at the CSP, and I'm also part of the CSP Health Inequalities project team, and I am your chair today. Next slide, please, Rosalie. Just going to get started with some very quick bit of housekeeping. So first of all, just to say the session is being recorded and it will be available via the CSP website um, quite shortly after this webinar, and it would be great for any of your colleagues who couldn't come today to please share it with them. Because there's a lot of us in the room, we're going to keep our cameras and our mics muted, often muted today, but we do want to hear from you. So please do use the little Q&A function, which should be on the bar at the top of your screen, to share your questions. There's no question too big or too small, so please do share, and we will do our best to answer them and get through as many of them as we can today. We have got the chat, and we will be sharing some pertinent resources in the chat as we go. So do keep an eye on the chat. And equally, please feel free to introduce yourselves and share any resources in there that you think would be useful for people to see. Next slide, please. So I just wanted to set the scene very quickly before I pass over to our main event, which are our three spotlight services. Just by saying that we know we have people in the room who are at different points in their career, different points of getting going with their equity work and their understanding of health inequalities. And that's absolutely fine. And we understand that the complex web of wider determinants of health, so where we're born, the education we receive, our gender, our ethnicity, the environments in which we live, to name but a few, which all determine whether somebody is more or less at risk of experiencing the impacts of health inequalities, can sometimes make it difficult to see where physio fits into this agenda and how as a profession we can make tangible impacts. And whilst there is no silver bullet, the message from colleagues and services already embedded in this work is really clear that physio services can make a meaningful impact by identifying the barriers and that limit access, and by working to reduce them. Through the great work already underway in our profession, we often see that small changes can make big differences, whether it's looking at your service or your daily practice through an equity lens, thinking about the data you collect and ensuring you're listening to the right voices. Every action matters and is a step towards making equity a defining feature of excellent physiotherapy practice. So, today we have three spotlight sessions, and we were going to hear from people who are already doing fantastic work in this area. They'll share how they identified their challenges, what actions they took, and what outcomes they've achieved, along with the valuable lessons and top tips. So hopefully we'll send you away some really practical ideas and feeling inspired. Next slide, please, Rosalie. Fabulous. So without further ado, I'd like to introduce our first spotlight speakers, Divya Narasimha and Jane Simpson, who are joint North Central London pulmonary rehabilitation leads in health inequalities, who will share their brilliant project focus on addressing health inequalities in pulmonary rehabilitation. Next slide, please, Rosalie. Fabulous. I'll pass over to Jane and Divya.
Thank you, Claire. Good afternoon, everyone, and thank you so much for joining us today. So my name is Divya Narasimhan, and I'll kickstart the presentation and then hand over to Jane to finish it off. Next slide, please. Right, so how were challenges identified? So when we thought about challenges, there are three things that we had to do here to understand the bigger picture, or to find the elephant in the room, if you like. One was the stakeholder engagement, literature review, and data. When it comes to stakeholder engagement, we had to go beyond our respiratory team. So we had to engage with the addiction services, the homeless outreach team, voluntary, social, and charitable organization to understand about the cohort that we are describing here, which is the addiction and the homeless population. Now, the voluntary, social, and charitable organization are people who have loads of knowledge about the cohort that we are talking about, and also they have good links into the community. Coming to the literature review, because Jen and I are respiratory physios by background, we do understand what damages substance abuse misuse can cause to lungs. But still, the literature review gave us information on the extent of the problem. Where do we have to look for resources? What has already been done? What are the lessons learned? How do we engage with this cohort, or why is that this cohort does not engage with healthcare? So all that kind of information came from the literature review. Coming to data, we did not have a ready-made set of data for us. So what I mean by this is the addiction and the homeless services, they have an understanding that COPD was prevalent among their population, but they were not collecting data on how many of their patients actually had diagnosis of COPD. So we don't have a number there. And the respiratory teams were aware that some of the clients that are referred into the service had COPD, and they were not engaging well with the service, but we didn't have, again, a number. So again, we had to go back into literature review and stakeholder engagement. So there were two literature that helped us to make some assumptions. One was a local study conducted by a respiratory consultant in one of the addiction service, which kind of gave us an indication of the X number of people that accessed that pilot at that time. A majority, we're talking about 90 to 95% of people complained about breathlessness. So that gave us an indication about the extent of the problem. And also from the addiction service, they gave us a paper which basically said, the previous year, out of the number of deaths they had in their service, 100% of their patients had COPD, even though COPD was not the cause of death, it was there. So it was all gave us an assumption of the extent of the problem or what we're dealing with, even though we didn't have the exact numbers. Next slide. Thank you so much. Now, what actions were taken to improve equity? Now, I understand this is a busy slide, but I just wanted to focus on the word access here. So when we say access, what we mean by that is access for the entire service. So the referral pathway and also access into the treatment pathway. So the entire thing. Now, staying the topic of access, we know in NHS, we have a tagline, taking the service to the patients. Now, in order to do that, as providers, we run clinics in the local health center, GP practices, probably in the community halls, church halls, shopping malls as well. These days have got clinics, which is all great because they are all the known places for the community. But the question here is, even though they are known places to the community, are they trusted places for everyone in the community, especially about the cohort that we are talking here about? Now, coming back to the referral pathway, as physios, I think we have a very rigid pathway, referral pathway. Like for pulmonary rehab, we get referrals from primary care, secondary care, maybe tertiary care, and a little bit of referrals from the other community services. If you are a MSK service or something like that, you might have a very good self-referral system, which is all great. Again, the cohort, the addiction and the homeless cohort, do not access any of the healthcare systems that I just spoke about, which means they don't know anything about self-referral. No one introduced them to self-referral. Even if they know about self-referral, they're not going to refer themselves in because of trust and previous negative experience. So the question here is, are we then accessible to everyone in the community? Are we visible? Are we accessible? So we had to take a couple of steps back to have a look at the pathway. And As a pilot, we did a lot of changes, but I think the learning now is we don't have to make a huge difference because we're all depleted with resources, but little changes here and there can make ourselves visible and more accessible to everyone in the community, I think. Next slide, please. Impact and outcome. So this is the result of the 14 months pilot that Jane and I ran. So as we received the referrals, we retrospectively went in to check how many of these patients have been referred to pulmonary rehabilitation before. And we found out that 90% of people were referred for the very first time during this pilot. Now, of those who were referred to pulmonary rehab, or of those we offered assessment, 85% actually attended the assessment. And our pulmonary rehabilitation quality statement says that referral to enrollment days should be within 90 days. And here we have achieved 45 days. Now, this 85% and the 45 days were all achieved because we were visible, because our treatment pathway was accessible, and also we worked with trusted partners like the addiction, homeless, the voluntary organization, charity organization, and so on. Right, coming to sustainability. For this project, what we wanted as sustainability is that we have access, like I said, the referral pathway access and treatment access for this cohort of patients. So currently we have 4 respiratory services covering 5 boroughs in North Central London, and all 5 homeless and addiction services have got access, direct access to refer their patients into pulmonary rehabilitation service. So we have removed the barriers of going into primary care, secondary care, and so on. And the treatment pathway is also integrated within the pulmonary rehabilitation services. Every pulmonary rehabilitation service is in different stages or different ways they are providing this. But some of them have actually started providing what we call as a whole respiratory pathway, which means the access into diagnostics all the way to pulmonary rehabilitation, in between the access to clinician, MDTs as well, and so on, which I think is brilliant. We have shared our learning widely through conferences, posters, publications, and podcasts, and so on. Some of the links for that will be on the chat for you all to have a look. Next slide, please. Right, I'm going to hand over to Jane, who will continue.
Thanks, Divya. So one of the things that we did as part of this was collect patient testimonials, which provides powerful learning and evidence for the impact of the work that we've done. These were taken both verbally and in written form, and patients were at different stages in their pulmonary rehab journey when we collected these. But I'd just like to focus on a few words in there. I feel valued. This isn't often the case. So typically with the addiction cohort and the homeless cohort, actually self-esteem is very low. They don't prioritize their own health needs. And that was something, feeling valued felt very positive. I think also we worked with Arsenal. So it was the Arsenal coaches who were working with us to provide the pulmonary rehab. And that as well, I think, helped involving another sector, certainly helped in making the patients feel valued. Confident. So I think this also relates to 2 things. One is self-confidence, and that's very much is improved by the way that we take, what approach we take as health clinicians with the patients, but also confidence in self-managing their own disease and symptoms. And what we did was we adapted the education part of pulmonary rehab so that the sessions were shorter to accommodate a lower attention span. We used a lot of visuals with the education that we provided, and we were very mindful of literacy levels within the group. Another thing we did was when situations arose during a class, maybe somebody was I don't know, more breathless, and we were working with them to regain control of the breathlessness. We would then reflect on that in the education. There was quite a lot of experiential learning went on as well. And structure, that was something which surprised us, and I think that might be our own unconscious bias coming out. But this cohort have very chaotic lives, and I think our assumption was that it wouldn't be achievable instilling a rigid structure within the program. But we were surprised. Actually, a lot of patients responded really well to having structure. So don't go into it with too many preconceived ideas. And dropouts, they were inevitable in PR, and they happened within this cohort as well. PR takes some commitment, which is one of the reasons, but the main reasons for dropout within this cohort were social and mental health issues. And also we found that it was very easy for them to lose motivation. So when there were multiple bank holidays, we had a much higher dropout rate. And one thing which was difficult was getting feedback once patients had dropped out. Next slide, please. So this is a patient journey. We'll maybe call him Philip. Philip was a 56-year-old gentleman who had lifelong asthma, poorly managed, poorly treated, and he was known to both the homeless and the addiction pathway, which is often the case. But his main point of, he was referred in by the homeless outreach team, and his main point of contact for us was his housing officer. We'll call him Alan. So a lot of the communication we used Alan in between, and it became apparent quite early on in his journey that actually he was illiterate, which isn't something he'd shared. And that was one of the reasons why working with Alan was really helpful. So when Philip first presented, he was quite angry. He was difficult in a group because he didn't take advice and so well, and he didn't pace himself. So he was a bit of a boom and bust sort of person. So he joined the group, and we were making headway, but then he went AWOL and he went to a commune in Glastonbury, had a light bulb moment, and came back several months later, and we took him back onto the program, and he was still smoking cannabis but not drinking anymore, and he was, I think, giving him that second opportunity really worked, and he could manage to complete the course of rehab, and then went on to act as an advocate within the service so that he would welcome new patients, and offer some reassurance to them. So I think that's really important. I think that was appreciated by new members of the group, but also we were confident that he was making safe decisions about his own self-care. So that was Philip. Next slide, please. This is the last slide, and this is for key take-home messages. I think for Divya and I, the learning has been immense working with this cohort of patients, and it was difficult for us to summarize key take-home messages because we just felt as if we had so many that we wanted to share. But I'll start with trust. Trust is, paramount really, and it's about being visible, working with trusted partners, whoever they may be. Be it housing officer, whoever, but work with trusted partners and in trusted places. And also very much taking a trauma-informed approach to this cohort of patients. And training was provided in order to support that. Next is engaging widely, which Divya has touched on. So even when it's difficult, so when we started the project, we we didn't have much engagement with users of addiction services and the homeless. That came with time, so we had to use the trusted partners in the interim. But don't give up, because we got some really rich feedback and engagement with patients further down the line. And also important to make the link between physical and mental health, really important. Research and data. So as Divya said, there will be some data available. You might not have everything that you need. You may need to make assumptions, which is what we did initially. So I think, yes, think about that, but also think about what data will be useful to you to help support further work. And we collected a lot of data, but sort of ultimately there were a couple of things that, looking back, it would have been helpful to have thought about sooner. Simplify and adapt pathways for all patients, not just this cohort. There are so many unnecessary barriers put in the way of patients, so keep it simple, offer choice of contact, means of contact, etc. Even down to relying on phones. With this cohort, they lose their phones all the time. So I think just really go back to the basics with pathways. And sustainability, that's the final point, really. So it's important with the cohort that we were working with, that they don't feel picked up and dropped. And I think they'll feel let down. That will enforce a cynicism about healthcare and why they're being targeted. So I think that's really important. Think about where do you want this service to go? How can you use the learning to adapt this service? And I think that's me finished. So I think we'll have questions at the end.
Yeah, brilliant. Thank you so much, Jane and Divya. Some amazing messages there around trust being paramount and really identifying and working with the trusted partners. But I also love your message around data doesn't need to be perfect. So thank you so much for sharing. Next slide, please, Rosalie. Lovely. I'm now going to introduce our next speaker, Wasim Ali Shah, who is currently working as an independent MSK practitioner over in Dubai, excitingly. But even more excitingly, he was part of the MSK service in Sandwell and West Birmingham, who undertook work using data really impactfully to understand the needs of his population. So Wasim, I'll pass over to you.
Thank you, Claire. Good afternoon, everyone, and thank you for joining this webinar. I'm Wasim Shah, and today I'm going to share how we used routine MSK service data at Sandwell and West Birmingham hospitals to uncover inequities by ethnicity and how we are turning data into action. Next slide, please. So our service evaluation led to a publication in the MSK Care Journal and is titled Clinical Characteristics and Variation in Musculoskeletal Complexity of Different Ethnic Populations Accessing Sandwell and West Birmingham MSK Service. And I've listed the co-authors of the paper on the slide too, just for credit. Next slide, please. So this presentation is structured into 4 parts. First, I'll go through the rationale and background, then I'll outline the key findings, followed by the actions and impacts, and finally I'll finish with some lessons learned from the service evaluation and advice for teams interested in carrying out similar work. Next slide, please. So our rationale came from our reading, research, and knowing that health inequality is a global public health challenge. Our aim of the service evaluation was to describe by ethnic group who is accessing the MSK service, to look at baseline severity in terms of function and pain, and when people present on initial contact, we wanted to sort of capture their health status from that point. Research has shown that persistent pain is a challenge, especially in ethnic minority groups. In the West Midlands, there's a growing migrant population. The general health profile of residents is worse, with significantly lower life expectancy and higher levels of growing deprivation. We looked at the Sandwell borough where the MSK service is based, and it's the 12th most deprived local authority in the West Midlands and has a 48% population identifying as being from an ethnic minority group. So where the service, MSK service sits, we've got quite a high ethnic minority population that access it. So we wanted to see who is accessing the service, with what severity, and what we could do as a service to better align care to need. Research has found that timely access to physiotherapy services has been a long-standing problem in the NHS, particularly affecting the most socio-economically deprived areas. Research also tells us that people in deprived areas experience more persistent pain and are more likely to have a long-term MSK condition and experience worse clinical outcomes. So that's what sort of stemmed us to sort of want to find out, are we having an impact on the population that we're treating? There is a lack of published national and local data from health organisations on the clinical characteristics of their service users. And we know that this data is important to aid researchers to fully explore the causes of ethnic health disparities. Next slide, please. So what we did was we framed our work as a service evaluation, but with a strong equity focus. Our main aim was to describe by ethnic group who is accessing the MSK service, to look at the baseline severity in terms of function and pain. And what we did was we asked questions around equity, like who's missing from the data, which groups present worse in health, do referral pathways differ, and are there any patterns in demographics or comorbidities that might give us a little bit more insight into the clinical characteristics or the health status of the individuals that are coming to our service. So this helped frame our work, and we kept the focus on access and variation rather than just describing averages. Next slide, please. So moving into how we put our aims into motion, we analysed routinely collected MSK service data over a 30-month period. We included new patients who completed a baseline questionnaire at first contact. Our key variables were demographics, comorbidities, the referral route, and we used 2 patient-reported outcome measures, which was the MSK-HQ and the MPRS, the VAS score. The MSK-HQ is a outcome measure that shows the higher the score, the better the MSK health. And the numerical pain rating scale is widely used to sort of document pain. So there were the 2 that we used. Then we used descriptive statistics and independent sample t-tests in Excel to explore variation across ethnic groups, and then we visualized them in graphs and analyzed them accordingly. Next slide, please. So across the 30-month period, we sent out 28,434 questionnaires and 13,248 were completed. So that's about a response rate of about 46%. Ethnicity data was available for 55% of respondents, meaning about 45% was missing. Among those who reported ethnicity, the breakdown was the white group reported 30.5, Asian group was 12.8, the black group was 4.5, the mixed group was 4, and the other group was 3.3. It's important to mention here that the high proportion of missing ethnicity data is a key variable. Missing data can mask inequality. So this became a key focus in our follow-up work on how we can try to reduce this going forward. Next slide, please. So our key findings are listed here. So of the groups, the overall mean MSK-HQ for our total sample was around 24.1 out of 56. So this indicates a relatively poor MSK health at initial presentation. When we broke that down by ethnicity, we can clearly see variations. The Asian group had the lowest mean MSK-HQ score, around 22.3, while the mixed group had the highest MSK-HQ score of 24.8. The white, black, and other groups fell somewhere in between. The pain score overall was 7.8 for our total population, which shows the severity and complexity of the patients that access our service. Among these, again, the Asian group reported the highest pain levels at 8.3, which was statistically significantly higher than the other groups. These differences suggest that people from ethnic minority backgrounds, particularly the Asian group, are presenting later with more severe symptoms of MSK pain and functional limitations. That's important because it highlights not just variation in need, but also possible barriers to earlier access. Next slide, please. So this leads on to this slide, which shows two other variables that we looked at, the referral pathways and comorbidities split by ethnicity. So the first chart shows the referral pathways. While the overall proportions look broadly equitable, we notice that white patients are more often referred through primary care, whereas Asian, Black and mixed groups are likely asked to self-refer. So on the surface, it might not look unequal, but it hints at differences in how communities access or are directed into care, perhaps due to language barriers, cultural factors, previous experiences, or unconscious bias in referral behavior. I do talk about this more in the paper, and I've got a QR code at the end for you guys to read. The second chart shows comorbidities. Here, interestingly, the white group has the highest proportion of comorbidities with 3 or more, while the Asian patients have the highest proportion of 0 comorbidities. So interestingly, taken together, this data suggests that although referral routes are broadly equitable, subtle differences exist. Once patients reach our service, ethnic groups present with different levels of health comorbidities and complexity. Even though white patients have more comorbidities, ethnic minority patients still present with worse MSK HQ scores. So again, it just shows that there is complexity, and just by looking at comorbidities alone, we can't explore why the disparities exist at baseline. So understanding both how patients reach physiotherapy and the health complexity which they present with is essential for identifying and addressing barriers to inequities in access. Next slide, please. So what do these patterns say? So first is that ethnic minority groups tend to arrive at our MSK service in worse health than white groups, which may reflect delayed or constrained access. Secondly, that patient-level barriers may play a role, for example, lower health literacy, language barriers, and digital exclusion, since our survey was email-based. Third, system-level barriers may also exist, including unconscious bias in primary care referrals, limited cultural competency amongst clinicians, and inadequate interpreting services. Finally, around 45% of respondents did not state their ethnicity. This is more than a data gap, it's an equity gap. We don't know who these patients are, but they may be disproportionately from marginalized groups. So understanding these factors is crucial if we want to design interventions that truly improve equitable access and outcomes. Next slide, please. Once we understood that baseline inequalities exist, we moved from insight into action. So at this stage, I just want to point out that I left the NHS here, but we did start some actions following the project, and I'll discuss some of the work that we plan to do as well. So firstly, directly after our evaluation, we shared the findings widely with clinical teams, equality leads, to generate awareness and buy-in about the issue. The service has focused on improving data completeness since then as well. This meant ensuring ethnicity is recorded and asked through better systems, for example, training of call center admin teams, and also physios during patients' physiotherapy sessions. A red dot sort of appears on the dashboard for physios to input any missing data, which will help us going forward if we was to run another cycle. We also embedded cultural competence and equity awareness into weekly clinical practice supervision sessions so that the data we collect becomes meaningful at clinician level. Other quality improvement work that we were planning to do was digitalization with the digital triage tool called FIO, introducing that into our service, and also designing and implementing patient experience work to hear directly from service users about the barriers that they get. So moving on from more quantitative work to looking at more qualitative data. Next slide, please. So this slide lists the impact of the project. So we've improved the completeness of ethnicity recording. The findings are influencing MSK service planning, and discussions with commissioners. Equity is now part of a conversation, not just an afterthought. And the data has formed a baseline for tracking post-treatment outcomes. So we've got data that shows people present worse on initial presentation. We can now compare it to post-treatment to see if there is a difference. And if there is a difference, does everyone improve the same amount, or is there differences in how people improve and how they respond? So moving on to some lessons that can be taken from this service evaluation work, and some advice for those who might be interested in doing similar work is don't wait for the perfect data. Use what you have and start to ask meaningful equity questions. Missing data can hide inequity, so make data completeness a priority. Make sure clinicians and service leads understand how to interpret and question the data. Involve patients and community voices early to validate and challenge the data story, and use data to spark dialogue and not blame. It is a sensitive topic, and previously colleagues have mentioned, uncertainty in terms of discussing it and confidence to discuss it, but we need to start empowering teams because that's how equity will improve, and to try to look at data as it telling a story of people, not just trying to look at the data as it's telling people's story from a different language, basically, that we just need to interpret and understand better. Next slide, please. So this is the final slide, which shows what we've done with the project. So as you can see, we've created a We Learn poster and shared that within the trust. Our service evaluation work also led to a publication in the MSK Care Journal, and I've attached a QR code for anyone who wishes to read and follow the methodology to use in your own teams and services, and hopefully try to meet the national recommendation of NHS Trust to try to provide more data and provide more analysis on people who are accessing it and where inequity and access falls short. Thank you for listening. Handing back over to Claire.
Amazing. Thanks so much. Data is an area which is so vital, but we know that people find really challenging. So thanks so much for sharing all that great advice. Next slide, please, Rosalie. So without any ado, we're going to pass on to our final spotlight. The final spotlight speaker, Sophia Mavramatis from the Adolescent and Young Adult Rheumatology team at UCLH NHS Foundation Trust, who will share her MDT's project, Pathway to Equity, Young People and Us Addressing Inequality in Accessing Care. Thanks, Sophia.
Thank you for the introductions. Next slide, please. So today, thank you for inviting us. I'm presenting on behalf of the service, and Dr. Aisha Burari, who's one of our consultants, honorary consultants and program lead for this project, but unfortunately she wasn't able to attend, so I'm presenting on her behalf. Next slide. So to put things in context, we are an adolescent and young adult rheumatology service. We're based in London. We see a local population, but we're also a tertiary referral centre. We have an adolescent service between the ages of 13 and 18, and a young adult service between 19 and 24 years old. In the adolescent service, we see a mixture of conditions that have autoimmune diseases, and they have musculoskeletal, mechanical, or chronic pain. The young adult clinic is a transition clinic, and we'll see the young people with autoimmune diseases. We're a multidisciplinary team, consultants, nurses, and physiotherapists, and we have a transition coordinator and a pathway coordinator. But we do work as part of a broader team with psychologists and social workers. From a physiotherapy point of view, we tend to work in the adolescent service, and we take young people up to the ages of about 19, 20, depending on their needs. And we probably have about 500 patients on our caseload at any one time. Next slide, please. So what I'm going to talk about today is the work we did with young people. So this was a co-production with service users, and to improve access to healthcare, but also empower young people to think more about their own health and how they manage it. So we had three work streams. One was the DNA predictor model. Then we did the patient partner engagement project, and then we had a community engagement project with schools. Next slide, please. has been a 2-year project, and through funding application, which was successful, we were funded by the Health Foundation, and we had 2 years worth of grants. Next slide, please. So how did this all started? So every service has DNAs. Looking at the pediatric and adolescent services within UCLH, we were probably looking about 10 to 40% DNA rate. Within the rheumatology service, we were around 15%. Now, in an adolescent and pediatric population, we don't tend to discharge patients after a DNA. We will offer them another appointment. But what that has an implication is that our follow-up waiting time increases, and we have particular difficulty fitting in urgent patients. And there's a waste of resources as well. So we were calculated between £1,600 and £5,000 a day, and a cost of over £1 million to the trust per year. And there's also the risk of staff burnout, because imagine we're having lots of young people emailing us, they've missed their appointment, but then they start flaring and they need to be seen soon. So what we do is we overbook them, and clinics run late, and everybody's exhausted by the end of it. So there's not only a cost implication, there's a health implication to our young service users, but there's a staff implication as well. Next slide, please. So what we wanted to do is to look at why these DNAs are happening. So we took a system thinking approach to the problem, and we used the iceberg model. So instead of just looking at the tip of the problem, which was, our 10 to 40% of DNA rate, we wanted to take a deep dive, work across the system with our colleagues and service users, and understand why young people are not attending the appointments. Next slide, please. So one of the first pieces of work we did was develop with our clever people who work in IT, is develop a DNA predictor model that would predict which patients are most likely not to attend their appointments. So this was using 64 features that's already embedded within our electronic patient records, and using clever statistics and coding, develop this model. The two key features were the index of multiple deprivation and the distance from hospital. So these would be the two key reasons young people do not attend their appointments. And through further clever statistics and coding, we improved the model from 69% to 80% accuracy in predicting which patients would not likely attend. Next slide. So we have the DNA model, and that we're working on that. And then in 2023, we started working with service users. So 9 young people volunteered, and we had a good representation of conditions between chronic pain, musculoskeletal pain, and autoimmune diseases. We only had 1 young man, and the 8 other volunteers were female. So we had some online sessions that we worked between September and December. This was an evolving project. So when we started it, we did not know where we would end up. And the brief was improving access to healthcare, improving how young people view and experience their hospital appointments, and how we could empower them to start thinking more about their own health and how to manage their health. So what the workshops led to was a face-to-face workshop in January 2024, which the young people called Hangout Space. And that illustration has been designed by one of our young people. And we all got together. So there was a group of young people and clinicians. And we had a whole day of talking and playing games and doing art and discussing how we could improve and move forward with our service. So the outcome of the workshop, and this workshop was co-facilitated by the young people with us. So the outcome of the workshop was to co-produce an interview script that we would then use to interview young people about their attendance. And also these 2 illustrations where the young people wanted to move from the top illustration is a doctor or a clinician talking down to the young people and the young people trying to voice their opinions, to a more collaborative approach. So working in a partnership in managing their health rather than we telling them what to do. Next slide, please. So we took the interview script that was co-produced and we did telephone interviews with 21 young people that were picked up by the DNA predictor model. And we also took the transcripts of the day, because we interviewed young people on the day of the workshop, and we did video recordings as well. So we put it all together, thematic analysis. And these were the key reasons why young people felt they didn't attend appointments. One was the practical barriers, so either cost or time of travel, us not communicating very well why they have to attend their appointments, or simply sending the appointment letter to the wrong place. Lack of awareness, so schools particularly not understanding why young people have to miss school to come to the appointments, and also compelling priorities. So young people are less likely to come if they have mock exams coming up, or A-levels or GCSEs, or parents missing work and not being paid if they miss a day's work. So these were the key reasons that came up. Next slide, please. So with the interview script that was co-produced with the young people, we then took the DNA model and we contacted young people between April 2024 and February 2025. 1,053 patients were picked up by the model, most likely not to attend their appointments. 510 patients were called. So phoning patients doesn't mean they're going to answer the phone. Everybody was called, but 510 people were spoken to. Over 200 patients agreed to take part of the survey. And the key reasons why they wouldn't attend appointments would be school, work, or the distance from the hospital. We did a snapshot audit of our clinics, rheumatology specific clinics, around spring 2025, and our DNA rate has reduced to 7%. We need to take a longer view of this now and get more more substantial data. But at the moment, we feel that the DNA predictor model is working. Next slide, please. So the final work stream of our project was school engagement. So what we wanted to do is go out into the community and see what young people think about healthcare and access. We worked with 3 schools. We worked with students from year 12 and 13, and we've coming to the end of our 2nd year of working with them. But how we approached them was arrange a first workshop where we met young people, told them about the NHS and about different professions, and explained our quality improvement project, and then gave them the opportunity to volunteer and take part. And that would be the 2nd workshop that we did online. So we had young people volunteer to be part of our project and go out and speak to their peers. And the 3rd workshop was coming to UCLH and presenting their results and given certificates and awards for their participation. Next slide, please. So the young people developed a survey about what would get in the way of staying well and looking after their health. And this was an electronic survey, and they just flashed a QR code with using their phone to their friends, and then the friends would complete the questionnaire, which was very straightforward, and I think it was about 10 questions. So we had 135 responses between the ages of 16 to 18. The majority were female. And interestingly, out of that small population, 25% of those young people had already a diagnosis of long-term conditions. So the key reasons that could be a barrier to managing health would be time and competing commitments, particularly around school, finances, high prices of food, unhealthy diets, misuse of drug and alcohol, and also feeling unwell in the first place. So if whether it was a mental health or physical health, that would stress them out and probably not attend an appointment that they had, whether it was their GP or with a hospital. Next slide, please. So where are we now? We've called our project a 4P model. So proactively identify young people who are most likely at risk of not attending. Within this project, we have tried to improve a peer support scheme, so connecting young people with each other. I think that's still work to continue. We are developing a population health hub, a digital platform with Hexitime. We're hoping it's going to go live over Christmas. And this has been Hexitime working collaboratively with young people from schools and our hospital, volunteers again, in developing a digital resource platform so they can, if they have a health problem, they can go in and click and find resources. And what we want to do is sustain our work with schools, and now the DNA predictor model is applied to all outpatient settings across the trust. Next slide. So from a physiotherapy point of view, what the project has given us the evidence to continue with this practice. We did start it before, but now we've sort of evolved more. So both my colleague and I, there's two of us in the team, work more flexibly. So we start late and finish late because young people prefer later appointments rather than early appointments. We give more flexible appointments around school holidays, so more face-to-face appointments around school holidays and more virtual appointments when the young people are at school or at university, so they don't miss lessons. And we're also mindful about festivities because we might give them an appointment, but let's say it falls over the period of Ramadan, then young people are less likely to attend. So we're mindful of that as well. My colleague and I have done, and the whole team actually have done health coaching. So we're having, I think, more non-directed conversations with young people rather than directed conversations, and helping them, again, take more control of their health. We give them a choice whether they want face-to-face appointments, virtual or open appointments. And I think we're shifting now from traditional exercises to more functional and independent lifestyles rather than thinking home exercises practice 5 times a day, and signposting to charities and resources. Next slide, please. So yeah, so practice is gradually changing. We're giving them a more enhanced reminders of their appointments and flexible scheduling, representation and sensitivity. So thinking about the diverse needs of the young people and working around prevention, both for mental health, physical health, and offering peer support. Next slide, please. And this is a list of resources, next slide, that you can access about our project. Next slide. And this is thank you for all the schools and the Health Foundation and colleagues who've been involved in the project. And next slide. And if anybody would like more information and email me, feel free. Thank you very much.
Amazing. Thank you so much, Sophia, for that really fantastic example and using patients' voices so powerfully. So we're just going to unshare the slides, and I'm going to ask our panel to put their cameras on, please. And we have some questions. Brilliant, thank you. So first of all, I'm going to start off with a question for Divya and Jane. There's been some interest in the chat and in the Q&A section about your flexible DNA policy. Are you able to briefly expand a bit more on that policy and how that has worked in practice?
Okay, Jane, I'll go, and then we're looking at each other, me and Jane. Right. I've answered that question in the chat, but briefly to say, I think we gave a very clear message to these people that discharge does not mean the doors are closed. Discharge does not mean that you can't come back again. It is all about we saying to them, we understand this is not the right time for you, but come back when it is the right time for you, kind of thing. And also because we kept in touch with everything went through the trusted people, which is the key workers or the housing officers, communication was a bit easy as well for us. And yes, we did have a softer DNA policy and cancellation policy as well.
Brilliant. Thank you so much. And I have a question now for Wasim. People have also been really interested, Wasim, in about the cultural competency training that your team have received as a result of your findings from your project. Are you able to share with us, please, just very briefly, what the contents of the cultural competency training was and how staff have received that?
So within sort of the service, we do weekly advanced practice sessions. So what we started to do within the sessions was just start to speak more about sort of different presentations, the backgrounds that they present with, and we started to just raise questions and sort of curiosity around sort of cultural practices that these different cultures and different patients have within them, and just have a bit more understanding as to how they might present or how they might be within their own home native countries, and sort of just being a bit more aware of sort of yeah, sort of their cultural practices really.
Fantastic. And how was that received by the team?
Yeah, very well. I think people were quite enthused and motivated actually, because they felt like they had a little bit more sort of dialogue that they could have with patients, and that made them comfortable and confident in how they approach patients. And it would also mean that patients would be a bit more warm to staff as well, because their staff are showing that they have a bit of cultural awareness in regards to their cultures.
Brilliant. Thanks, Azim. And Sophia, we have a question for you that's just popped up in the chat. Just asking, will your DNA predictor model be available to other trusts? And could you give some tips on how other services can start to look at this where they work, please?
So it's a very good question. It will very much depend on what electronic patient systems each hospital has. So Aisha has currently been working with another team from Wales to help them set it up, because they've got a different. So if anybody's on Epic, like UCLH is, it will be a copy and paste. But if you're on a different electronic system, you'll probably need to build this model. But it doesn't cost a lot of money. So what our colleagues in Wales have done, have got a master's degree student who's doing maths, and they've got them doing the clever statistics and coding. So, and the variables tend to be already built into the system. Like it can start something simple like age and gender, previous DNA rate, postcodes. So yes, so it's not difficult to build, but it depends on what system you have.
Fantastic. Thanks, Sophia. Now, I do apologise because we have had such a wealth of information through our talks that we haven't got any more time to pick up on further questions. So I do apologise. Anything that we can pick up on and get back to people, we will. And thank you so much to the speakers who have been able to answer questions as we've been going through the chat. So, Rosalie, I'm just going to bring up the last couple of slides to close. So just to say that the CSP Health Inequalities Project are continuing to work on developing our resources, and we will share these in the post webinar email. So don't worry if you don't get time to click on all the QR codes now, but I just wanted to pull your attention. Our frontline article, we've got a series of articles coming out looking at the challenges of access, experience and outcome for physiotherapy services. We'd also love for you to join our Health Inequalities ICSP to get involved with the chat and discussion. It's a really great way to link in with colleagues and with the project team. And also keep an eye on our Health Inequalities CSP web pages, which are evolving and developing currently. And next slide, please. And we would love you also to sign up for our next webinars. I say this is a series of free webinars, and the next one is taking place on Tuesday, the 16th of December from 12 till 3. You can click on that QR code, but again, I will put this out in the post-webinar email, and it's going to be focused on Every Voice Matters, elevating patient experience through equity in physiotherapy. And we're going to be looking at some really important points around work that people have been doing to enhance patients' experience through co-production, through community engagement, and through cultural competency, as just to name but a few. So please do sign up and come back and join us for that. And final slide is just to say a really big thank you. Thank you so much to our speakers for joining and for sharing so generously their fantastic work. Thank you for everyone in the audience for joining us and for all of your questions. And a massive thank you as well to our CSP team behind the scenes, Sarah Murrell, Helen Sharma, Kat Lawrence and Rosalie Bevan. I'm going to close the webinar. Thank you so much.